Obviously, she can type.
Yep, she can
Figured
type.
it out.
So thank you all for coming and joining me on my little webinar here. This is a webinar that I have, the content itself is something that I've been teaching for years within the context of my work as a palliative care nurse. And in the capacity of my palliative care work, I've worked both at bedside at palliative care units and hospices in Vancouver, and as an outreach nurse who does some education work with families and staff, and then also clinical consulting to basically take palliative care work outside of the hospital. I've worked in long-term care homes with frail elders and their families, which is really the area of passion that I'm most interested in. And what ended up striking me through the last 5 years of heavy work that I've done as an outreach educator, I most consistently get feedback from staff and family to like, why don't we know this? Why don't we talk about this more? So this is one of my first efforts to not only make this information more accessible for people, but also to teach people the simple tools that I have ended up developing with my team over the years to provide clarity to an area that can be really challenging to bump into on all manner of dimensions when we actually bump into it. The specific focus that I really wanted to narrow in on was looking at caregivers, because being a caregiver myself and having worked with so many caregivers, it seems like caregivers, especially when it comes to working with frail elders, are the key pivot point, because they are often, experiencing the major shift of role. Maybe they're coming from, maybe at first just doing pivotal or doing important supportive caregiver function to becoming the main spokesperson or the main voice of advocacy for the elderly person themselves, and without being supported by a culture that talks openly about death and dying and makes that kind of conversation transparent, it's hard, because I hear that caregivers feel like they get thrown in and they get cast in, kind of blind to situations that are not only high emotion, but also high stress and, high confusion. And being on the flip side of it, what I've come to see as a healthcare provider is that a lot of the times we see things that are essentially patterns. They are predictable changes and transition points that we become very used to seeing as caregivers, but we're not doing the work of being able to speak proactively, to talk to families and elders about what's going on. So that's all the background context of why I'm doing this today. And the other really, personal bit is my grandpa. My grandpa died when I was 13. And when I reflect back and I think of, the turmoil that my mom went through, the grief that I went through, and understanding how, ultimately the last couple of years of his life where he had the key kind of like milestones that were very predictable now in my experience. If I had known, the key time markers, would I have done things differently with my grandpa? Would my family have experienced things differently? So I have a personal vested interest in helping people navigate this time of their lives so that they can have more clarity and have decreased suffering in all respects. So that's a little bit of the background context. As I mentioned, the first hour of the presentation, I'm hoping to just be able to go through some of the key content stuff, and then the last half hour will be for any questions, and feel free to pause and type or raise your hand or however during the presentation if you have questions. So next slide. It's not going. Come on now, silly thing. Aha. Okay, so the three, basically, presentation comes down to three major pieces. One is just navigating impact of disease on function over time. That sounds pretty wordy, but I'll talk more about that. Two is the whole piece about what is palliative care, what's the palliative approach, and how can it be helpful. And the third piece is the four key questions to guide conversations about care. So I'll spend approximately equal amounts of time on everything. And the first piece is just getting everyone grounded on the same page, which is talking about navigating how disease will impact an elder's function over time and how that's likely to affect you as a caregiver. So the inspiration from this piece basically comes from the fact that, once again, the whole patterns issue. The whole patterns thing. You know, in my reflections, it seems kind of funny to me that, or strange to me rather, that in, you know, looking at the developmental milestones of a child's, first 3 years of life, or the developmental milestones of each month, each trimester of pregnancy, we have so much clarity and so much understanding as to what that looks like, you know, what to expect in terms of changes. And then when it comes to our whole piece around death and dying, it seems that, especially for North American culture, we've lost the one, willingness to talk about it openly, and then, of course, two, we don't have as much clarity around the developmental milestones of what that actually looks like when somebody is approaching the natural end of their life. And to complicate this is the fact that it looks very different depending on what's going on for that person, right? So in an attempt to try and bring some clarity to this piece and to bring some what to expect kind of clarity, I have used a piece of research that seems to make a lot of sense for family members. So frequently I'll talk about this, and I'll show you the diagrams leading up to it. But basically what I wanted to preface was to think about how function and how somebody's function changes over time depending on the disease they have. So the first piece is kind of anchoring you into this diagram, which basically looks at, you know, how does somebody's function change over time? So on this axis, if we look at function being 100% or 0%, 100% is like being independent. You or I being able to do whatever we want to do, walking around, feeding ourselves, bathing, showering, everything you know, without any impediment. And then time is just as a function of what birth, you could say birth to death. And if I go more specifically into function, it's the time that I look at first. Time, I would like to invite you to think about it in increments of, you know, time in hours versus time in days, in weeks, in months and years. So I've started off the axis as, you know, birth to death approximately, but you'll see how as we talk further on this topic, the hours, days, weeks can really shift and change depending on what's going on with the elder that you're looking after with their disease. When I talk about function, what I mean is, as I've said, you know, independence, the ability to do meaningful activities, and this relates to the fact that typically when we look at the definition of frail elder, you know, there's a couple of qualifications for it. One is just the basic age piece, which is generally it refers to an elder that's 65 years old, or somebody who's 65 or older. And then the other piece to it is, and I think this is the real crux, is who needs assistance with their basic activities of daily living, which means, you know, your basic ability to bathe, cook, to get around and, you know, walk around and mobilize. So a frail elder is often somebody who has both of these things, and a lot of the times they often need so much help with the activities of daily living that usually they end up moving into an institution if they're not able to be supported at home or by families, because of course, as you can imagine, the more help they need, the more time consuming it is to have caregivers be able to be present for them. And then it gets, you know, we go into a whole bevy of complexities related to the issue of the availability of caregivers. When I look at the issue of functionality, there's a tool that usually comes up that sometimes I'll show families to talk about the clinical frailty scale, which is a tool that's been developed by Dalhousie University, which basically just puts pictures into, often what are the major things that come up with elders. So somebody who's, not very frail, so they're very fit. You can see there they've got their hat on, they're going for like a jog, right? They're robust, they're active, they're energetic, they're motivated, they're able to independently engage in activities that are meaningful for them. And then as, the frailty scale goes on, then it can show how their physicality changes based on their function. So somebody who's well has no active disease but are less fit than somebody who's very fit. Somebody who is managing well has medical issues, but they're well controlled. So they're active, but not regularly beyond routine walking. And then as we get further along, this usually, what ends up happening is that these people would be considered that their function is lower down. So somebody who's very fit would be function level of 100%, whereas maybe somebody who's moderately frail, their function's down to maybe 50 or 60%. So people need help with all outside activities, with keeping house. They have problems with stairs, might need assisting with bathing and queuing, all of these kinds of things. And then you can see that it goes on to somebody who's very severely frail, which is, somebody who's completely dependent on others for care, approaching the end of their life, and typically they could not recover from even a minor illness, as an example. And then, of course, somebody who is terminally ill in this scale refers to somebody who has a life expectancy of less than 6 months. There's the little caveat for scoring people with dementia as well, and the degree, it says the degree of frailty corresponds with the degree of dementia, and you can see that shows up in somebody's, not only their cognitive ability, but over time it starts to affect their physical ability as well. So if I'm going to go back a little bit, actually. Oh, no, not letting me go back. So if I go from this picture of being able to see just, in pictorial form how function changes, I'm going to refer you back to the picture of function over time. So you can see that as somebody approaches, the natural end of their life, often their function scales down. And why this is important is, how do diseases affect function over time? As I've mentioned, different diseases affect function differently, and then also the relating to time scales differently, whether it's a matter of years, months, or weeks. And often the tricky thing is, I find that this was especially true to me when I first started nursing, is our culture tends to think about, the relation between function and time as something quite black and white. Often, I put the little dinosaur there because I think of it as like catastrophic changes, right? I think this is why we're often afraid to talk about death and dying too, because people forget that there's a whole gray area of changing function and a whole gray area between how somebody's illness affects them that precedes their actual death. So often, in our culture, there's, we think of somebody as being like 100%, then all of a sudden something happens and then they just, straight plummet and die. And the dinosaur refers to that kind of catastrophic event, whether it's like a car accident or being eaten by a dinosaur, literally in Jurassic Park. And this is a disease trajectory map that does exist, but it exists for sudden, unexpected incidents leading to death, where somebody is truly functioning at 100%, they don't seem to have any evidence of disease on them, and then something, happens and then they die. But this actually is a very small percentage of how the majority of the population dies. What's more likely, and this is kind of big picture, so I'll walk you through it, is that what we have come to see is that people actually die through a variety of different causes. One of them, one of the major ones is cancer, somebody who has mostly cancer as a disease. Another one is somebody who has any kind of long-term chronic organ failure as a disease. And then another one is just is frailty, dementia, brain diseases or whatnot. So this is taken from research that has kind of divided up the three different disease impacts and how they look over time. And the key thing to keep in mind about these three pictures is that they all refer to somebody who has underlying a disease pathology, or they've got some kind of like a medical issue going on that is either irreversible or terminal, chronic or progressive, or all three of these. And these are kinds of the words that I tend to use with families to refresh and kind of cement in the understanding of the fact that with medicine, I think it's very common for us to think that medicine cures things, but the reality is our Western medicine doesn't actually have the ability to cure and obliterate a lot of our chronic diseases. If anything, we modify the disease and we keep it in check over time, but eventually the diseases end up reflecting and impacting people's function. So when we look at the three different trajectories, or the three different maps of disease, the first one is one that I'll spend the least amount of time in because it's somebody who has mostly a cancer trajectory. So we could see that their function is, high or independent to begin with. And this may be, the timeline might start when they are actually diagnosed with cancer. So it might not start at birth, but it might be, upon diagnosis of cancer. And we can see that for the first stretch of time, their function is actually quite high. So this could be referring to somebody who may be diagnosed with perhaps like a colon cancer. And for the first stretch of their disease, they are able to, maybe they've had surgery quite early on, and now they're undergoing chemo, or they've had radiation or whatever it is. So their function initially is not very much impacted. Usually this period of decline here heralds the fact that they may have had a metastases or the news that the cancer progresses. So this slope refers to the fact that the cancer has moved into a different phase where perhaps, whereas before it might have been that it wasn't, there was still ability to prolong the cancer, even if it is terminal, or there's still options to keep the impact of the cancer showing up on the person's function quite low. When somebody's function starts to decrease, it usually heralds the fact that, the cancer is now in a different stage. It's progressed. It's progressed beyond the ability for us to manage it, so to speak. So usually the steep decline in function can look and feel short, like this could be months relative to the time of diagnosis. And often when somebody's function starts to deteriorate, and this is the same for all of the graphs, they usually end up in some kind of like a healthcare institution. So this is particularly true with cancer, with people who have cancer who are on a more on a trajectory where we see that their function is starting to fail. So the next map is a map of somebody who has, it says here, mostly heart and lung failure, but it can actually refer to somebody with potentially, diabetes who's starting to have kidney disease as well. It can be, and I like to think of this as any major organ disease. Liver disease would fall into this category as well. And this middle trajectory tends to be a trajectory where definitely we know that the disease is chronic, so it's kind of like an ongoing behind the scenes, and people are usually, the care for them is to basically take care of themselves better over time. And we can see that the timeline starts with somebody's function who's already, midways, who's already, not super independent. So this could be somebody who maybe they're 70 years old and they've had diabetes that's been hard to manage since they were 40. So that represents 30 years of challenging diabetes to manage, and maybe they started on hemodialysis 10 years ago, something like that. So we could see that their function to begin with is not fantastic. This is perhaps somebody who relies on a motorized scooter when they leave the house, and inside the house they use a walker perhaps. And the interesting thing about this middle map is that each of these dips usually represents some kind of like an attack. And when I say an attack, it means usually it's an exacerbation of what's happening for them. So if we say it's somebody with like a heart issue, perhaps one of these dips is an acute congestive heart failure episode, or a small heart attack, something like that. And the dip in function represents that they are actually, functionally very sick for a short amount of time for whatever that is. So the lowest point of this might represent a stay in the ICU for 2 days. And then the rise means that, okay, after their 2-day stay in ICU, they're returned onto the regular hospital floor and they're starting to get up and do activities with the physiotherapist every day, and they're getting back to their baseline function. But we can see that over time, these attacks, are likely to happen again, and that slowly their function, they never recover their function. They're slowly getting a little bit worse over time. And we can see that in this map, the representation is that often it looks like, these attacks can get clustered together and then they're not able to actually recover from this. But usually with the heart and lung failure trajectory, this first part can take, often years. And the last part of attacks getting lumped closer together can look or feel like, a shorter amount of time, whether it's a short number of months or a short number of years. Whereas in the cancer trajectory, it can be this little stretch in the end here can be maybe in the month time span, and all of this can be years as well. And it's a contrast to the final picture, which is a lot of the time for elders with advanced brain disease, advanced dementia, Alzheimer's, any of these things where we can see that their function starts off quite low already, but they have kind of like an up and down period. And the thing about the prolonged dwindling or this particular map is the fact that this pattern can go for years. It can go for anywhere from 6 to 8 years, depending on what else is happening with the elder and the other diseases that are functioning at the background to them. So often when I work with families and elders who are living in long-term care facilities, and I can't remember, I think of the surveys that I got back, the only there are 2 people who are looking after had family members in assisted living. So I suspect that, usually when somebody's in assisted living, they're still quite functionally able to do things for themselves, be able to walk down the hallway and have food or whatnot. When I work with elders who are in long-term care facilities, what ends up happening is they're usually a mashup between these 2 maps together. So they often have a background, a background long-term, maybe medical condition, on top of the fact that, their multiple systems overlapping with each other are starting to show more impact on their function. So this is kind of the big picture of what's happening. And it relates very strongly to one of the first key questions that I'll speak with you all about, because it's so important for families to understand what's going on, because as you can see, sometimes it can look quite complex, right? And we have people that come from such a diverse people coming from such diverse realities showing up into care and needing support. So I can, I see sometimes elders with that are very well supported and regularly seen by a bevy of specialists. And even with all of that medical support, families and the elders themselves have a hard time understanding and picturing together what the big picture is. And then there's some elders who, have stayed away from the doctors for years, and they show up in hospital, and this is kind of the first time that they've shown up on the radar. And according to our assessments and the tests, we are able to navigate them along one or two of these trajectories, and we start our conversation from there. So this is a picture showing how 3 different families of diseases are likely to impact somebody's function over time. Hi there, Anne. Welcome. I just saw you. So I debated whether or not to put this piece in first versus my 4 key questions. And actually, what I'm going to do is I'm going to go do the 4 key questions first, because I think it seems like it fits better, and then I'll go back to this piece. So I'll slip through. So the 4 key questions, the reason why I like to do the 4 key questions and teach the 4 key questions is because we have all this, we have, it seems, a reluctance and a discomfort to talk about death and dying and to talk about what's really going on within healthcare. And I certainly see it, our research shows that healthcare practitioners are, scared of saying the wrong thing, and that our families look to healthcare practitioners to open up conversations. And certainly in my experience, it seems like there's this cloud of, fear to talk about what's happening. So in the years that I've worked as an outreach nurse, I see kind of thematically the same 4 questions or the same 4 points that have to be navigated in talking about death and dying, and talking about making healthcare decisions, and talking even really about really upstream conversations with even my family members. I've tried this on my parents just to, speak with them. And I find that over the last couple of years, I've really worked on teaching people, or kind of getting people to frame their mind around these 4 questions, whether they're family members or staff, just because they help bring clarity to whatever's going on. So the first question, or all 4 of them, to lay it out is, what's going on? What do we expect to happen next? What's the most meaningful outcome? And what's the plan going forward? So this is the most simple framework. If we were to make it a little bit more complex, it's zeroing in on each one of the questions. So the first question is, what's going on, right? Essentially, it's what's going on here. And if we were to make the conversation a little bit more specific, because this really can scale from a casual language, casual as, hey mom, so tell me what's going on, what have the doctors told you about what they're doing for you? It can be from, as simple and as casual as this to, having family meetings where all the healthcare practitioners are brought in, the attending physician, the cardiologist, anyone who's involved in your parents' care or in your neighbor's care, whoever it might be that you're looking for. Usually, we start with this foundational question to ask what's going on, to basically ground each other in the same reality, in the same understanding of what's unfolded. So this is an essential question to understand context. So this is usually where, diagnosis and prognosis comes in. And often I find that a lot of the conflict, a lot of the misunderstanding stems from, this very first piece of information. Because as I mentioned, within healthcare, I think sometimes we get very insulated in what's normal for us or in what we understand. And then with families, they don't always get to hear that, and they don't always get to weave together the whole picture of what's going on for their family member, even the elder, right? So the first piece, the very most important piece, is to hear, what does the elder think is happening, what does the family think is happening, what does the healthcare team think is happening, and then is it possible that, based on everyone sharing their perspective, is it possible that we can come to a common understanding, a common grounding, a common reality moving forward? Sometimes it is possible, sometimes it's not, but at least it's a really, really important start to be able to actually, begin our conversations from here so that we actually understand each other's perspectives. An important thing to keep in mind at this point is to compare what's different time-wise, because even though, and this has happened as well, even though families may not agree with the healthcare team, one thing that we can all agree on, or we can all kind of look at, is how people's function has changed, from present day, from today, compared to a month ago, or compared to a year ago, compared to 6 months ago even. And part of that is because it helps us to understand, what do we expect to happen over time. So once again, this is the second piece of what's happened, of the question format, where the first piece is just asking, well, what's going on? The second piece is asking, well, what do we think is going to happen? What do we hope is going to happen? So the pictures that I showed you earlier, the disease trajectory pictures, the the ability to talk about within the healthcare perspective, within the years of witnessing and research that we've done as caregivers in hospital settings, what we expect to happen with people over time, particularly if they have disease burden, is that we expect their function to get less, and that they will need more help, and that they will be able to do less and less as they come to the natural end of their life. So it's important that, in healthcare, I think, and intrinsically, I think everyone has an understanding that this is kind of the natural progression of things, but it's really important to actually explicitly talk about not only what do we expect will happen, but most importantly, what do we hope will happen. This, I think, creates the bridge, particularly when you're in the role of advocating for family members, because it really drives home, and it, is a nice bridge to the next question, which is, I forgot that I put this here. I just wanted to show the whole piece of, what do, within the healthcare context, this is what we expect to happen over time. So I can refer back to this map, and often, what I'm doing with families is, I just ask them, so what's been happening? Tell me mom's story of not only this hospital admission, but maybe, when she first started getting sick, however long that means to you, just tell me your story. Tell me what you remember the most. And while they're speaking, what I often do is I'm jotting down the key events, right? Had a fall in January 2014 and all of that sort of thing. So I'm marking down milestones, and I'm marking down changes in their function. I also listen for if, if they know mom had a heart attack, or mom has heart disease, or mom has lung disease, because what I'm trying to do is I'm trying to create for them their own picture of one of these disease trajectories. Once again, from, it helps ground them in what's going on and what to expect to happen. So I usually find that when I do this for families, they're thankful for it, because the thing is working in this area of healthcare and in this time of life, it can be a really challenging one, because it forces us to have both feet in the like straddled in the world of, concrete clarity, what's been happening, but there's also a ton of hope and a ton of like not knowing what's going to happen next. We know kind of big picture that perhaps our frail elder is in the last, year of life, maybe the last few months of life, and there are markers which correspond with each of these diseases. Like for heart function, we can test different things like somebody's ejection fraction, and there's various scales of somebody's breathing capacity with, lung disease that in a numbers picture, they tell us when somebody's functioning at this level, when their organ is functioning at this level, that they're more likely to be in the last year of their life. So, from a medical perspective, we all are coming to, and I think arriving to, the same proximate picture. But of course, the trick is to be able to acknowledge that while remaining very present to the fact that they're not dead. they're maybe dying and approaching the natural end of their life, but given that, how do we help them live in deep ways that are very meaningful for them, and how do we care for the elder and their families in ways that are very meaningful for them? So that brings me to the next question, which is, well, what's the most meaningful outcome? And how can we support this outcome as a team? And this is one of these questions that is, again, it can be very micro-specific, and it can refer to, again, an elder who's in a hospital setting, and we're talking about whether or not we want to start dialysis on them. But then we can also scale it back, and it can be, a conversation that you're having with your mother or father about how they want to manage their diet, knowing that they are recovering from a heart attack, right? It can be scaled to big picture versus very specific. But the interesting thing about this is that it goes back to the question of, well, why are we doing what we're doing, right? If we look at the progression of what's going on, what do we think or expect will happen? And in the example of, how strict do you want to be with your diet for heart disease, if we go back to the expectation question, we know that, heart disease, if we're not taking care of the of diet, we're not focusing on exercise, we're not looking at stress factors, then we know that that's going to be hard on the heart for the years, the months, or however long they have. And it all depends on, the person's function. So if that's what we know what will happen, if that's what we expect to happen, that if they don't manage their, whole picture of health, that their organ will suffer, then the question would be, well, what's the most meaningful outcome then? If they want to be able to live, and what matters for them, what's important for them to be able to do. So it can start, this is an example of asking the question like really, really early on. And like I said, it can be, a very acute situation when we're looking at very specific interventions that are on the table for treating somebody who's in hospital. But then the other thing that this can come up in is in long-term care situations. When we are looking at, an elder who already is quite functionally impaired, and maybe they're only awake for, 4 or 6 hours during the day because they have quite advanced dementia, and maybe they're not able to verbalize or articulate a lot for themselves. Still, even in this context, we can ask, what's the most meaningful outcome for the elder as we know them, right? What's the most meaningful outcome for mom as we know her to be? And then why we need to know this is because then we could figure out how we can, as a team, support the elder, the person that we're caring for, to have the most meaningful outcome. So we start from what we want to happen, and we develop our care plan around that, rather than, what can happen in medicine is that things will go wrong, or there will be, markers that are wrong or incorrect, and relative to, the picture of a normal, functioning, healthy person. But we have to adjust our perspective when we look after frail elders, because we know that, over time, as disease shows itself and impacts somebody's function, the values that we are looking to correct we won't be able to, achieve them, because fundamentally their organs are not going to be able to correct themselves back to baseline as they were before. So it's a slightly different approach to asking, what's the most meaningful outcome. And then the last question is, when do we reevaluate? So based on whatever the plan is, whether it's okay, well, for maybe mom is only going to eat, I don't know, if maybe she'll eat, fried food once a week as opposed to every day, or whatever that it might be, right? And then should we talk again in a month? The whole point of this question is that it's important to have the conversation, but it's also important to make sure that we're grounded in a time context again, when we can look back and see, based on what we've discussed, is what we're doing meeting our objectives. And I speak in generality, but when I look at another example is, and I'm trying to do this is a little bit trickier because I'm trying to speak to a very broad context rather than my usual very narrow group, which is, somebody who has basically an elder living in long-term care, who might be looking at the question of whether or not they should go to the hospital versus stay in long-term care. In that context, when, it's a matter of treating a pneumonia or treating an infection, because the other thing that's important to know is, I'll flip back to the diagram here. The thing about these two diagrams, the chronic disease and then also the frailty, dementia, brain disease, is as these two maps kind of collide together, because, over time, people's organs, of course, they're interrelated systems. So one organ system that was, acting out might start to impact other organ systems. And at the very, broad level, it basically means somebody's immune system is compromised. So over time, the likelihood that an elder is going to be more susceptible to an infection like pneumonia or a urinary tract infection is very common. And one of the conversations I have the most frequently is, well, what happens when we know that they will get an infection? How do we want to treat it? And, within within modern medicine, we often have the ability to offer antibiotics, but the effectiveness of the antibiotic, whether it's an oral route or an IV route, varies according to how much the disease has affected the person's function. And then, of course, what's important to them, especially if so often having the treatment, kind of the ability to have particular treatments varies with where they are. So an example is in long-term care settings, IV antibiotics would not be an option for an elder. So they would have to go to hospital in order to have IV treatment. But is that going to be something that the elder would want if they are, quite frail, and, we expect that over time that they would, probably die from a pneumonia? These are the kinds of complexities that I end up having to, parcel down and talk to families over time. And it's way, way more easy to do that if they have all of this context, like all of this understanding, because basically what we end up doing is we end up parsing down the little tiny bumps and divots right before somebody's, death. And often it's within the last, the timeline we're looking at then is weeks to days to hours sometimes, right? That we end up speaking to them about. But again, my ability to have those conversations is so much more easy when they have all of this context in the background for them, because a lot of these conversations, due to their content and everything else that's happening for families and their caregivers, these need to be repeated a lot over time. So, like I said, the last question is what's the plan? What are we actually going to do, and when do we check back? And how quickly we check back is usually going to be related to, the type of intervention we're doing. Like I said, if it's, a course of IV antibiotics, then it's easy. It's when the IV antibiotics finishes. If it's more generalized, then, it could be let's check in a month to see how the elder's doing. So I've already said, it's really important to repeat these questions. So these 4 questions, I expect that people, you start that whole cycle of the 4 questions like years before your parent ever needs any help, because that's when it's at its best. And then even when they go into hospital, it's often, the 4 questions will repeat again and again and again. And you'll hear the framework even in fancy, formal care meetings, because that's essentially what we talk about. So for audience interaction, I wonder if you guys could let me know the 4 questions, just off the top of your head.
What's going on? What's happening?
What's happening? What's going on? Absolutely.
And
what do we expect over time?
Yep. What do we expect over time?
What's the plan? Or what do you want? What do you want?
Yeah. What's
the best outcome?
What do we want? The most meaningful
outcome, right?
Exactly. And then you're absolutely right. And then what's the plan? How do we actually make that happen, right?
Mm-hmm.
Yeah.
4 questions. So what's going on? What's likely to happen next? What do we expect? What do we want to happen? And what's the plan? Different ways of saying the same stuff. So other important considerations. I'm going to go back to the whole palliative approach thing at this point, because, basically when I'm within the context of hospital settings, I feel like palliative care is always in the background, but I haven't actually talked about palliative care here. So so what is palliative care? Anybody? Do you guys know what palliative care is, or what's your experience been with palliative care?
I always thought that it had to do with keeping the person as comfortable as possible as whatever it is that they're affected by continues on its course. So it's not huge interventions. It's how do we keep them comfortable?
Mm-hmm. Absolutely.
Or when everything's been done medically that can be done, and so it's usually I consider it hospice, the next step.
Mm-hmm.
Mm-hmm.
Yep.
It incorporates both of these things, actually, and the definition formally changes a little bit from country to country, and even like from facility to facility. But basically, because I think in the United States, hospices are usually the confusing thing is palliative care is both a theory, like an approach to care, and it can also be a location of care. Same with hospice in the United States. And the definition of like timeline when somebody would be considered appropriate for hospice care or palliative care varies according to the definition regionally of what they mean. So I'll show you the main diagram that I like in terms of breaking it down, which is palliative care is holistic assessment and care planning with the patient and family in the context of irreversible or terminal, chronic or progressive disease that affirms life and honors dying as a natural process. So usually palliative care refers to, 2 things. The things that people, always think, talk to us or associate most easily with us is the symptom management piece, the whole, comfort, being out of pain, not having to suffer through nausea, shortness of breath, or that sort of thing. So there's the whole symptom piece. But the whole other piece, the piece that I'm really focusing with you tonight is actually the conversation piece, where, palliative care basically strives to keep, and this really should be a fundamental core in all medicine, but sometimes we forget or we, lose track of it. But we keep what's the most important thing for the patient or the family at the core of what's going on for them. And their meaning, their why is why we treat or why we do what we do. So, when somebody isn't looking at, when we don't have an endpoint, when we don't have a finite amount of time associated with care, it's easy to lose track of that. But when we know that they have a finite amount of time because their disease is irreversible or terminal, then the whole piece around conversation and making the person's wishes the most, the keystone, the cornerstone of why we do what we do, it becomes really important. But when we come to, looking after elders, it could be tricky and confusing because the whole disease process of what's actually happening with them totally varies, right? This is why understanding how different diseases might impact people over time helps to give us more of a ballpark around what timeframes we might be dealing with. So this is my summary picture of basically the much more wordy World Health definition of palliative care, which I won't go into. I will show you a picture of, how when I started working in palliative care 8 years ago, even 10 years ago when I first started nursing, and this is still the same in certain parts of practice, when people would hear palliative care and they'd say, nope, they're not dying yet, so it's too early for you, right? Nope, don't talk to us about, it's not time for palliative care, because they basically would think that in context of disease, there's curative care, trying to save somebody's life, trying to, get rid of the disease. And then when we couldn't do anything further, then we'd switch to a completely, comfort-focused approach. But in reality, we can actually do both at the same time. And we've actually seen that looking after people's symptoms, particularly in the case of, an example that we've got actual evidence-based research on is managing shortness of breath in lung cancer. If we're able to manage people's physical symptoms earlier, then they could potentially live even longer. So in this case, we can see that, particularly in the case of, cancer trajectories, that we can do disease modifying or potentially curative, like radiation therapy or surgery or whatnot, alongside doing supportive and palliative care, like managing their symptoms and talking about what to expect over time. So this is a better concept, and the thing that I love about it is that it also really honors the whole piece of bereavement and how grief happens even before somebody's actual death, and care of the caregivers needs to continue to happen even after somebody dies, right? So I appreciate this diagram much more. This is a big picture that, I can make available to you by sharing the slide, but basically it shows that palliative care, or a palliative approach to care, is very broad, and it incorporates, everything from just introducing palliative care philosophy to end-of-life care, which usually means that somebody has, a shorter timeline, like their last months to weeks of life, to terminal care, which refers to a very specific short period in somebody's life where it's the immediate hours or maybe days right before they actually die. So the approach itself is, like I said, both a theory of how to care for people, and it can correspond with, locations where we actually can provide palliative care to people. But because, it's very broadly associated with death and dying, it can be confusing to understand that palliative care can look very different in how much or how little it's involved, or the theory is incorporated into your care depending on what phase of disease you're in. Often, the thing that is really being acknowledged right now is that there is such thing as a palliative approach to care, where basically it's exactly as you said, Luca. We look at comfort being the focus of how we plan to care for people. Because when we ask people, what is important for them and how would they like to be cared for, often people say, that they They want to be comfortable. They don't want to have pain. So often a palliative approach to care is appropriate for elders because it focuses on taking the principles of palliative care and applying them to the care of people with, chronic conditions. And it focuses more broadly on conversations with the elders and their families in a much more upstream approach where, we talk to them early about their needs and their wishes, what they define as being, comfort for them, what's important for them into their care, and, providing all of the information requirements for them so that they can approach the natural end of their life, whether that is a timeline of like last years, 2 or 3 years, or last months or last weeks, with much more clarity. And then I've gone through the 4 questions, and basically the last little piece is, the other important considerations to is, specifically for the 4 questions conversations. I often talk about this in the context of like family meetings in hospitals, but it still remains the same. Like who do we need to be asking these questions to? Is it mom, to understand like what's going on for mom, or what's her understanding of what's happening for her? Is it the doctor? Because there's been a lot of health concerns that have been going on, and it seems like there's not a lot of clarity in terms of what's the big picture here. So asking who needs to be involved in the conversation is important. There's, of course, really important to clarify perspectives, right? It's this whole issue of managing realities and understanding, separating out the patient's voice or the elder's voice, and understanding what's important for them versus what's the medical agenda, or what our own agenda as a loved one, as a family member might be, even if our intentions are for the best, right? So being able to clarify out people's perspectives is really important. Just making time and space for conversation is really important as well. And like I said, this can be in terms of making sure that there's a big formal sit down with all the healthcare professionals, or it can just be setting an intention to check in with our family member to see what's going on for them if it's been a really challenging year and there's been a lot of changes. And then finally, there's usually when I start family meetings, if we're talking about, these 4 questions in a very, formal context, I lay out, why we're talking about this, and often it's because there's been a lot of health changes, and I kind of acknowledge that the reason why it's important to talk about these is so that we can make sure we understand what's important to the person, so that everything we do can honor, the person's ability to be engaged in the meaningful activities of their life. And I think documentation moving forward. This is more for a healthcare context. It's repeating. It is being able to, one of them I've talked to you about, be prepared to repeat these conversations over time. So the 4 conversations: what's going on, what do we expect to happen, what would be meaningful, and what's the plan. Expect to repeat them anytime that there's a change in health condition. So, after mom falls, after she moves from assisted living into long-term care, anytime that something changes in somebody's functional status, it would be a good time to talk about, what's going on again. And the more that we talk in frequency about what's going on, I think the shorter the conversations can be, and the less confusing they can be as well. Because sometimes, I have these conversations where we start about, what's going on, and we're trying to weave together 5 years of changes for an elder, which can be kind of overwhelming to navigate through, and for the family to assimilate, and understand what's happening for them. And ideas for future offerings. For all of you, yes, all of you are aware of my work in both context of my palliative care nursing work, and then also my work as a hand analyst that does non-predictive hand reading to basically help people with their own self-awareness. So as I was workshopping some of the needs that I encounter with caregivers, with families, with staff, often the topics that come up, and I found this with the survey responses too, where, caring for caregivers, the issue of, how do I deal with guilt? How do I know that I've done enough comes up. Caregiver burnout is huge in terms of both formal caregivers and family caregivers, and trying to figure out, how to be able to do meaningful work as a caregiver, but balance that with being able to caregive for ourselves, so that our other relationships in life, our other responsibilities in life are not eclipsed and consumed. And then there's also, the other topic that seemed to come up through the surveys with people is, just how to talk about this stuff, right? So it's one thing to offer 4 questions and 4, simple phrases to open up conversations, but being kind of in the hot water of opening up these conversations with family members can be challenging in and of themselves. So, I've thought about in the future potentially doing more focused topics on these 2 topics, and then figuring out a way to use hand analysis in them, because hand analysis offers a way of getting potentially very specific about understanding our personality, motivations, and challenges that can arise when it comes to these hot button topics. And finally, thank you so much for participating.
Thank you.
I've gone a little bit over in terms of, my estimated time to share, and I feel like I've given a lot of information. So I just really wanted to thank you for, being present and hanging in here and having listened to everything that I've had to offer. If this is helpful, please tell your friends and family. I'll send around another quick survey to see if there's any feedback that you have based on the topics tonight. And then the other third piece is if you'd like to continue working with me, then I'm here.
Yay.
I've got references and thank yous. And finally, I'd like to open up, open up the floor for questions to see if there's any particular questions that you bumped into that stuck out in your mind as I was going along and in the slide work.
Joni, I have a question. My dad, who's been a long-term heart patient, since he was 40, and he's now 84. And he's still working, and he's had a couple of bypass surgeries. And it's not new to our family, the heart care. But in January, we almost lost him to an event where his EF went down to 30. And, anything under 35 is, bad. Mm-hmm. But so that's when they brought us in, and his cardiac physician kind of laid out, what the options were, but we hadn't had these conversations. And my brother and I weren't ready to not intervene and do another angioplasty and see what was going on. And sure enough, the stent, he had a blockage that was able to be stented, and he's back to work. Because he's a worker bee, and he's got to be working. Yeah. So, but since the event, I've noticed he looks different, just older, more frail, a little slower, and but still trucking. He's still going. But it's hard for me because I've got all 3 aging parents in my backyard, and with different issues, some cognitive, but all still functioning. They still take care of themselves, feed themselves, et cetera, but just so to have these conversations when they may not be willing to go there, it's just to be there and catch them when I can, so it's hard because especially with my father, because I've really, really noticed, I feel like, although I'd like to believe we have another 10 years, that's the home stretch, but I don't know now. I don't know.
Mm-hmm. Yeah, I would say that's the tricky thing is, there's the there's, I think with your dad, and it sounds like with your parents that are all still, independent, I think that's the trickier part of being a caregiver, where you're standing back and wanting to potentially open up the conversation to see if they're willing to talk about it. For some of it is for very practical purposes, like, designating a power of attorney or doing advanced care planning. So, that would be the same, when somebody's still able to share their own decisions, if they're still cognitively intact, if they can still articulate their own wishes. One of the ways of being able to open up the conversation, and not make it be about, like, I think you're going to die necessarily, is,
Right.
advanced care planning along that angle. But
Right.
I can understand too that it's, tricky. And for somebody who is, 83, 84 to have had heart interventions, his functional status, must have been pretty darn near 100% for them to be able to, offer that, because some of it is just purely, when it comes to deciding, that piece about what do we expect to happen. Some of the interventions are, risk versus benefit.
No, we talked about that, and the irony was, asking, Dad was not going to be a cardiac cripple. In other words, if he left the hospital without any more stuff, it would pretty much wrap up and see how long he can go.
Yeah.
You know what I'm saying?
Yeah.
And if he couldn't work, you might as well pull the plug right now.
Yeah.
So going the way we went, and we bought more time, because instinctively I felt like we were going to have more time. But had my brother not been in the medical end of things, not a doctor, but enough to be dangerous, and pushed his cardiologist to because with advancing age and cardiac issues, there's more doctors now specializing in there's a term for it, when age and cardiac issues come together. What's it called? There's a name for it, but there's more physicians now, just not in our area. Mm-hmm. But in any event, I'm the kid that's got the 3 parents in my backyard, and I'm ready, I think. so I'll be looking forward to those caregiver workshops, as things change. But it's scary. I'm 59. I met, the love of my life late in life, and my parents are aging. And so everything's colliding at once. Mm-hmm. And so not feeling guilty, because I'm trying to be with everybody, and thank God my dad, my stepmom, and my mom all get along. So it's great. Mm-hmm. So, but it's and I'm intrigued by the aging process in general. I'm trying to make sense of it, because I think that for our generation, and what we're up against, and the whole state of the planet in terms of relatedness, that we need to know how to age honorably. Mm-hmm.
So there's, you go ahead, Luca.
I was just going to say, I feel like I'm listening to what you're saying with 2 hats on. One of them is, what do I do for my mother? My mother is in a very similar position to your father, Debbie. She's 82, and she's just been diagnosed, because it took them, they've misdiagnosed her for years. So now she's gone from she was limping along to now she's critical, and nobody's telling us what's happening. But I'm also, the other hat I'm wearing is, what happens when I get to this stage?
Exactly.
Right? And how do I help myself to manage myself as I go into all of this, because I don't have any children. Right. So there aren't going to be children to look after me when I get to this stage.
Right.
It's so, I'm trying to
each other.
Yeah, I'm trying to be preventive, and I'm also trying to, I figure as I go through this with my mother, I very much believe that the dying process is part of the living process. Mm-hmm. And that how we help people into the final stages of their lives is a mark of what kind of progress civilization we are. And I also think, you know, the baby boomers are going to go into
Yep.
this. And I'm on the tail end of the baby boomers. So,
Yep.
and she's, you know, she came before that.
Yeah.
So I'm looking at this as, how do I keep her as involved as possible? Because with heart problems, there's nothing wrong with her brain.
Right.
She doesn't have dementia or any kind of diminished brain function. Thank God.
Right.
And she's also very willing to talk about the dying process and making plans. But we haven't had the level of detail of conversation that we're talking about here, because we didn't even know about it. And
Right.
I don't know how you go about accessing somebody like you, Joni, who, like, where does this come in the process? We don't have a GP that's telling us about this. We're not in care facilities. The only way we've been anywhere near a hospital is in the emergency room. They're not telling us about any of this stuff anywhere. You're my first access point for any of this.
Mm-hmm.
Mm-hmm.
Well, and that's where the advocacy comes in, because I think it's almost like you have to know. I mean, Joni, when I met you in hand class, it was so great because of who you are, to know that you were a palliative care nurse. It's like, oh my God, we put you
Gives
everywhere.
me hope.
Yeah, it's like we put you everywhere. But now we know to ask for it, or or to look for the facilities that offer that.
Mm-hmm.
Yeah.
Absolutely. And I think that's the big thing, is to be able to ask for it, because people, don't know that palliative care exists, or there could be, a palliative approach to care. Ideally, like I said, everyone in healthcare could offer and could functionally, take a palliative approach to care at a basic level. But the nuances are tricky, right? Being able to sort out that whole piece about what's going on, and to figure out what part of the health disease can we reverse or can we keep at bay, versus what part of it can we not anymore. You need people, and where the palliative expertise comes in is to be able to help, parse those hairs out and be able to keep that treatment going that is, in line with what the patient wants, right?
Well, did you read the book Being Mortal?
I haven't yet.
So I recommend that to the gals who are on this webinar, because it was so eye-opening. Because at the end of the day, the medical doctors in general are thinking curative, and
Yes.
they're coming at it from that perspective, and that's the race. The race is to what can be done, as opposed to when do we decide to ask the patient and the family, what's the best outcome. And like you said, Joni, some interventions can have a worse outcome, than letting them go home and have a quality of life, et cetera, et cetera.
Mm-hmm.
But that's why that book, Being Mortal, written by a physician, it was such a great book.
Mm-hmm. Mm-hmm. Absolutely. And it's interesting too, because I find that particularly with our, sometimes I racked my mind trying to figure out how to share this information, because my mind works really broadly in terms of, I've shown you function over time, disease trajectories that are universal, but then there's actually, a concept of, what's, if we exercise our awareness, what impact is that, how does that change the game? Because I think the other piece when we're looking at being caregivers is, really, honoring the person who you're caring for, their reality, and what's likely to change over time for them.
Right.
Versus, how that, how you're witnessing that might actually change your reality, right? Because a lot of what I've also noticed is a consistent theme of working with people when we start talking about this death and dying stuff is often, it's in, and why I want to focus on looking after caregivers is often people who are witnessing or who are caregivers to a close family member dying. Often their whole world, gets reevaluate it.
Prioritize.
Exactly.
Yes.
The whole question of like what is meaningful, that really they start living their whole lives about what's meaningful, right? So this is
Well, it's like having a conversation like to your parents. Like my dad loves sugar, but he's got borderline diabetes and my mom, and I'm sitting there going, okay, do you want to, what do you want? Do you want to continue to eat this way? Because it will make you not feel good. So maybe mom, you're tired because your diet sucks. You know what I mean?
Mm-hmm.
But if you don't want to change the diet because it's too much effort and you're 83 years old and it makes you happy to have frozen pizzas, then have your frozen pizza.
Mhm.
But this is the struggle. Or do you want to feel better? How long do you want to live?
Mhm.
Yeah.
And then it gets really tricky because, generationally we see differences, right? I see
Right.
like the older generation, like, it's a generation of your parents, they can be, it almost seems like they fall into two camps. One is like follow what the doctor says versus like I'm going to do my own thing, keep me out of hospitals, right? It almost seems
Right.
that disparate, whereas generations where like the baby boomers, they're much more self-determined. So I think as
Right.
they grow older, and they're essentially, I think it's the baby boomers that are driving the right to die conversation, right? And
Right.
and having their wants, their needs, their clarity around how they want to be supported as their function declines as they get closer to the natural end of their life. That's a totally different animal altogether, which I think is why this is fascinating. And at the end of the day, the more information we have, the more clarity we have, the more willing we are to talk about these things. That's really what's important, right?
Right.
So, Joni, when you were talking about if we wanted to access your help, what does your help look like? I mean, what does from both the hand analysis perspective and also from the palliative care perspective, what does help look like, and how does one go about accessing it?
Thank you for asking, Luca. Right now, the only thing that I've got fleshed out is the hand analysis perspective, because then it helps doing an individual one-on-one hand reading that looks at basically fingerprint stuff, which kind of elucidates what your personality style in terms of communicating. Well, that's more hand stuff in terms of communicating versus what's your personality style in terms of, or rather in the fingerprints, they talk about the use of your energy and where you're more likely reflexively going to be challenged. So I wonder if with caregivers in particular, a lot of it might be, the guilt stuff that comes out of, somebody who has a lot of service fingerprints. So for the hand analysis part, that's more just understanding your personal mechanics. With the palliative care nursing part, to be honest, I haven't fleshed that out yet. Right now, I think my immediate plan is just to do a whole bunch of free one-on-one kind of like assessment and like mapping or navigation modules, and then thinking of offering that as a consult or as a service. But I'm still really new on formalizing how I'm going to offer my palliative care knowledge with people that's outside of my nursing framework. So for now, it's...
Well, I was just thinking it might be what you do with the hand analysis. I mean, having had hand analysis, I haven't had it from you, but I've had it from Jill. And my mother has had it from Jill.
Cool.
So she's done like the full 90-minute whole thing, right? I'm thinking to myself that the hand analysis really lends itself to the conversation end of it, to the preparation end of it, to the having the ongoing reevaluation before you even end up in the care facility, because it would help everybody to be more aware of what it is that they want out of life, what's not done yet, that they, how much time do they have left to do it in?
Yeah.
How do they prefer to go out? How do they prefer to be cared for? How do they hate being cared for? How do they feel about dependence and independence? Like, it seems to me that what's in the hands would really help, especially if you're looking at a team of people coming together for the conversations, right? If you've got the family member, the family member may be the same as the caregiver, but if they're not, then both, it could be the person's partner, it could be their GP, it could be the palliative care staff, like whoever it is. Everybody has their different, even within their professional function, they have their different preferences and what they're better at and worse at and enjoy more, and it might help everybody to find their roles within this process.
Absolutely. That's the whole next adventure of work, is for me to slowly weave together my visibility and my skill sets between the two worlds, which is thrilling and scary and awesome all at the same time.
I'm not sure you have any competition. Like you could just define it for yourself, because people are either in the care facilities or they're not, right? There's nobody that helps us to make the transition.
Mm-hmm. Mm-hmm. Mm-hmm.
And I just see real value, Joan, and thanks a lot for what you've talked about. But I see real value with caregivers, and I'm not, it's not my parent that I'm helping somebody with their parent who's actually in a care facility who has dementia. And then another friend whose partner just had a brain hemorrhage. And I think basically he doesn't know, they don't know still what the trajectory is. I guess that's the hard part too, is really feeling involved in the definition of what's going to happen, I guess, because a lot of times it takes time, I guess, to observe somebody. Mm-hmm. But I just think, even just this is a very small group, but I can see just having an online presence and advice for people who are moving between home and facilities and really trying to navigate their way through knowing what their rights are as caregivers. And, I think there's just those basic things too, I think would be really valuable for people. And I'm thinking particularly, like the person, my friend whose mom has dementia, like really they only have a once a year, 20-minute, or maybe it's twice a year, but, a team dialogue where she's involved. Mm-hmm. And I mean, that's it.
I know.
Really.
I know. Part of why I'm trying to do this too is because I've worked within that system, and I'm like, are you kidding me?
Yeah.
Yes.
Yeah, and if you don't get your questions in fast, you don't, you have to wait really to
and that's if you even know what the questions are.
Well,
I don't know what the questions are. You how do you even figure out by the time you figured out your question, the meeting's over.
Yeah. No, so I think that's, that interface is really challenging for people.
Yeah,
I agree.
It's a good start, Joan.
Thank you.
Yes.
Thank you all for being a part of this so much.
Oh, it's wonderful. It's wonderful. Thank you for doing it.
My pleasure. Well, now you know where you can come to if you've got continued questions or whatnot. And, I guess stay tuned. Thank you for all your contributions to this question discussion part. And thank you for all the work you do. I'm sitting amongst an amazing group with Luca and Debbie and Anne and Annie. Annie is one of my sister's best friends' sisters.
Ah, nice.
And she's studying to be a nurse. So
Oh, wonderful.
Well, she's got a good model here. Good model.
Yes.
That's great. I'm glad you got this going, Jane. Yeah.
And I will continue to.
Yeah.
Thank you all so much for participating tonight. I'll send out a little note about survey and how to access the recording as well, so you can share, okay?
Great.
Fantastic.
Thank you. Good night.
Thanks, Joan.
Thanks, Joan.
Bye.
Bye.